Good morning, everybody. I am going to talk with little bit more exhaustive and basic oriented mostly. So, SCC, which is now going to be a challenge in coming days with treatment of disease or detections. You can see now, if you think of liver cancers, 90% is SCC, and mostly it is in our world that is developing. And if you go to this map, the NASH related SCC is rising, and you can see the contribution is close to 35%, and in India is at its peak. So NASH related SCC is rising, and at the same time, the India we are getting the challenge because of this SCC related to NFLD spectrum. And if you see the Asia, the similarly we are struggling also in most of the parts, and Asia and India are the lead for the SCC, particularly as far as NASH as the etiology is concerned. But you can see why we think to discuss here NASH as a separate entity as far as etiology of liver disease and NASH is concerned. This develop with or without cirrhosis. Type 2 diabetes increases by 2-fold. Presence of metabolic syndrome, it increases by 5-fold. If you see the obesity, more than 35 BMI, increases 4 times the risk of developing SCC in a NASH or cirrhotic person. And NF-related tumors are mostly the large, and they tend to be hypervascular. They are often diagnosed very less, and now studies have shown that they are responsive less to the immunotherapy. And because we think them they are simply NFLD or NASH, the screening surveillance is still not updated for the NASH in absence of a cirrhosis. So that's why they are a different entity altogether as far as SCC is concerned. So now if you go one by one, the metabolic syndrome, you can see this is with obesity. There is a spectrum of hormonal changes we can say are the adipokines. You can see here, these are the adipokines like adiponectins, adenosine, ghrelin, and they are leptin resistant. They are anti-inflammatory, and here is the pro-inflammatory, which progress from NFLD, they progress to the NASH. Similarly, liver is an endocrine organ. Like the release of hormones, is the hepatokines. This you can see the phenytoin, RBP, hepcidin, FGF20 helpful in progression to the NASH. Further, they progress in addition RBP4 and FGF19. They make it to progress to the NASH to cirrhosis with or without cirrhosis. And these two, ANGPTL8 and ANGPTLR4, these are been as hormones released by the liver, they help themselves to develop a tumorigenic environment to develop SCC in NASH. And most important thing that if a diabetic, we give the drugs, and mostly in our OPD, and before getting the slides also I am not aware how the anti-diabetic drugs we prescribe, and they are influencing a NASH patient to develop cirrhosis. The highest risk till now is sulfonylurea and the insulins. These two, the most widely we are using for the diabetic NASH or a NASH cirrhosis, are considered to be the more pro-tumorigenic. So hence, I think we have to now think of when treating a patient of NASH or a cirrhotic with diabetes, the drugs for the diabetes should focus more on the SGLT2 inhibitors, metformins, GLP-1 or thiazolidines. Already we are using the GLP-1, SGLT2 is now coming up. Metformin has the highest advantages. I think we should focus these 4 group of drugs. Insulin obviously when it's uncontrolled, but we can take the polypharmacy as far as NASH or cirrhosis is concerned to decrease the risk of SCC to be developing. Then next important is the how a diet and a cholesterol and lipids. So this is here high fat, high cholesterol diet and high fat, low cholesterol diet, and they shown that in animal model for the development of SCC, and the SCC development in this animal is close to 80%. And this is more with high fat, high cholesterol diets. And this is the simply the principal component analysis where they have shown that this pathophysiology of developing SCC is because of this gut microbial diversity. And this microbial diversity has been shown to be here that when you give atorvastatin, they have a both modulation of the gut microbiota as well as the SCC prevention, development of the risk is getting lowered. So similarly, the next important is the what we eat. We can see that the diets we know which are being high fat, high sugar, even little bit of high fiber also, they are altered the gut microbiota. And you can see here the each components of the microbiome has different implications for cholesterol, for fiber, for fat and the sugar. When they all combine, they are the harbingers for a person to have NASH and subsequent development of the SCC. And as you know, the SCC happens in an inflammatory milieu, and a NASH cirrhosis has multiple folds. You can see the development tumor-prone microenvironments, loss of cancer immunosurveillance, loss of cytotoxic activity, dysfunctional NK cells, loss of cytotoxic activity, that is exhausted CD8 cells, CD8 T cell inhibition, IL-10 and IgA, regular T cell expansion happening, which is little bit of anti-inflammatory, and a regulatory T cell deposition, TGF beta. So this is whole explanation which is going on in NASH from the onset of inflammation with cirrhosis to lead to develop and SCC. Then next you can see the how in cirrhosis there is a reprogramming of metabolomics and lipidomics. As we have discussed, the metabolic syndrome, dyslipidemia. So these are the various metabolites has been found in the analysis on the metabolic channels. These are the groups which are helpful increasing the risk of SCC, and these three are to decrease the risk of SCC. And when you go for these products, they are called as targeted, not quantified, targeted, quantified. Most important, you can see here as the vitamin D. If vitamin D related ergocalciferol, alpha calciferol, folic acids, pantothenic is going down, and there is a more prone for developing SCC. And non-quantified are the lyso groups, and here I have mentioned these are coming up. So here is very interesting that in vitamin D, which is we most often see in clinical practice to be on the lower side, are a harbinger for the SCC, but this is, I think we have to think in clinical practice how we can correlate to this. Then important is, as we see the metabolic spectrum is going on, similarly how individual metabolic component is responsible. You can see the glucose metabolism, protein metabolism, lipid metabolism, gluconeogenesis. All these are targets, comes hand in hand to make a therapeutic pathway, and the intervention accordingly can helpful as a metabolic therapy for prevention or treatment of the SCCs. So these are various plant products has come up, which are not has come into practice, but still in vitro and in vivo, and they are helpful in preventing. And you can see here the most commonly till now resveratrol. This is already comes for the portal hypertension, and this is also helpful in stabilizing. Then flavons, they are also helpful in through the HF, HK2, GLUT1. So these are the various metabolic pathways which we can address to consider. And interestingly, this is one plant products. This is a tree which has now comes as an extract which targets the multiple metabolic pathways in glycolysis, lipid, amino acid metabolism, and it has shown to be that it is helping to decrease the dose of seraphin for the dose as well as toxicity. So this is where a science is emerging, the metabolic therapy being for the metabolic component as the NASH, which can helpful for prevention and even in treatment to be an adjunctive effects. Then as we discussed, the first part is the metabolic syndrome, metabolic components and metabolic therapy. Then comes the next necessary level is gut microbiome. This is what happens in a person of hepatitis B or C, and in the NASH there is a leaky gut which cascades the sign for the inflammations, which produces dysbiosis. There is release of metabolites which goes on producing the atmosphere which favors the development of a SCC. And this is a diversity in NASH various parameters which I can say here in this slide. The bacteria, you can see the good and bad. As far as SCC also concerned, particularly in NASH, there is also a variation. You can see here the Acinetobacter is going up, Verrucomycobacter is going down, Bacteroides ruminosis is going up, Bifidobacterium is going down. So this is all are happening. B and C are also there in Hep C. So there is a definite profile of gut microbiome which are promoting inflammations and promoting SCC developments. And this is in due to that they develop a immunodysfunction. You can see here, this is a study where the PBMC has been isolated the Treg and CD8 T cells, which are has been higher in SCC than control than the NASH, And in go to the inflamed milieu, ILT, IL-12, there is a distinct different phenotype as far as NASH SCC is concerned for the immunodysfunctions in the periphery. And this immunodysfunction leads to development of the SCC. Similarly, this immunodysfunction is by the metabolic pathways, metabolic models. Here you can see the most commonly the coming it is the pyruvic acid and the butyrates. That means the short chain fatty acids which are released by the gut microbiota are the one of the major harbingers for this development of SCC. So when you consider SCC as to be considered in a NASH patient, this is dysbiosis. There is bacterias, rumino, bellino and clostridium species going up. There is increase in butyrate and acyrate and formates, and this transmit through the leaky gut. They supports a peripheral immunosuppression to happen, that is Tregs are going up, CD8 cell is going down, and this butyrate propionate is the main culprit, and this further leads to progression to develop a SCC. And if we thought that gut microbiota is the one of the target, is it therapy can helpful? Yes, these are the few therapies you can see, mostly the yogurts with enriched with bacteria. There is heat treated enterococcus mixture, mostly yogurts, probiotic mixtures, multistrain probiotics, symbiotics. So these are come up as a recent individual studies, but this opens a therapy, a window that these persons can be treated or no. And very interestingly, this is one study so that immunocheckpoint inhibitors. If we are giving immunocheckpoint inhibitors to a SCC patients, there is some change in the gut microbiota, and this can be a signature for these who are responders, who are the non-responders. So this is only 130 patients studied in a group. Here I think we can think of this, if you are giving the immunotherapy, how this gut microdiversity has been getting changed. And the suggestions that whether FMT can be considered in this group of patients if gut microbiota therapy is to be considered in case of NASH which are progressive, non-responsive, and even therapy failures are there. Then next important, this coming as the fecal metaproteome. That means you consider the microbiota, you find their organism, find their products, and how they are helping to diagnose this. So this is very interestingly, this group of proteins has come up, and they have found a model which is close to 86% for developing a prediction model. That means if you get a stool, you go for the fecal metaproteome analysis. With that, you can say that this NASH patient is going to develop SCC in future. This NASH cirrhosis can going to develop a SCC in future. So this is also one futurity concept of analyzing the stool as well as proteomics and also fecal gut microbiota to help in predicting them. Then one we found the distinct entities coming up, and the genomic landscape is also different. You can see here in a NASH patient there is difference in these protein mutations. You can see here the TOT, CTNB, TP53, SCVR2. These are the major 4 genetic mutations which are found in NASH versus other etiology for the SCC. If you found NASH with or without cirrhosis, this is also having significantly the TOT and CTNB1, these are coming up. So there is a definite genetic landscape where we can find that whether this person is going to have SCC in presence of cirrhosis or NASH versus other etiology. So that can be a good prediction model. Similarly, you can see the mutational signatures and signaling pathways. These signaling pathways, the mutational signatures MUT-seq, NASH, MIS-seq24, and the whole genome expressions, and also the metabolomics in fatty acid, bile acid pathways, RAS antioxidant pathways, in inflammations, they have a distinct signatures. So when you think of a NASH SCC, you can find a signature both in metabolomics, in mutational signatures to identify and quantify them. Similarly, the cancer field is diverse. In case of NASH, it is fatty acid, cholesterol, bile acid related, oxidative stress, DNA repair in relation to inflammations, and some mediators like IL-6, STAT3 and STAT5. So you can see a predictions across the spectrum from healthy to control and to healthy cirrhosis and NASH without cirrhosis. And this is the adjacent tumor micro tissue. So the tumor micro environment surrounding of the SCC, the NASH itself, cirrhosis, and healthy, there is a spectrum of diverse landscape is existing which can be explored to define a person who can develop SCC in future. So just to summarize what we discussed, the most frequently are the genes are the TOT, CTNB, TP50 and SCB are two-way. And these are tumor suppressor gene which is typical of SCC than others related to NASH. If there is Wnt and TGF-beta proliferation are more prevalent in SCC than other etiology, and they can have a pro-cancerogenic effect which we need to explore. Hence, we need a combination approach of whole genome sequence which is available with us. We can go for the microarray to know their immunofeatures. We can quantify their molecular class. So, whole baskets with these pathways in form of bile acid, fatty oxidation pathway, immunosuppressive fields, and mutations. So, we can give a complete diagnosis of this person with NASH or NASH cirrhosis, whether he is at risk of SCC or no. By this, the global challenge we can think of, but definitely resuscitating. As we see the genomic landscape for the NASH, is it epigenetic different? What is epigenetic? It refers to a heritable trait not attributable to changes in the DNA sequence that can control chromatin structure and the express transcription machinery to DNA, and hence they modify the gene expressions. And C, they can be a writer, they can be eraser, they can be reader. So they affect the chromatin except the DNA modulation, the surrounding pathways. You can see the acetylation, phosphorylation, methylation, and a lot is there. And how it is in NASH is coming up. You see a normal liver to a cirrhotic liver and SCC progressions. There is the histone post-translational modification is unique. Expensive epigenetic modulations are getting unique, and these mutations are also unique. So this gives a epigenetic signal for the NASH SCC to develop cirrhosis. And these are the various trials which are already considered on the epigenetics, and few of them for the SCC. You can see here sorafenib with oxaliplatin and this durvalumab with this SGT110, and this is one belunostat. So these are drugs are in various phases of trials which are considering for the NASH SCC to be treated based on the epigenetics. And this is the group what we discussed, the writer inhibitors, readers inhibitors and erase inhibitors. If you think of one by one, this is a little bit difficult to remember, but I think this is a food for thought. What we see a lot of patients, we can make this as actionable on epigenetics. So we have discussed from the beginning pathogenesis and molecular spectrums. Now if we consider therapies. So when you consider immunological spectrum for a SCC and NASH, they have a different stripe. You can see that TH1, TH17, TH2, they have a triangular relationship. CD8, CD4 has a relationship, mutual. M1, M2 phenotype of macrophage is a potential way, and NKT T cells going on. And then they are developing a complex interrelationship. So what we see that if a tumor is there, if CD8 is more, TH1, TH17 is more, NKT cell is more, and M1 phenotype is more, then likely the tumor is going to be progressive. If CD8-4 is nearly same, you can see here, then there is partial tumor inhibitions. If the things are going the other way, you can see the complete tumor inhibition. So for a person with SCC, if CD8 count is high, if TH17 and TH12 are balanced, NKT and NK cells are balanced, and phenotype is equal of M1, M2, there that you can find a good response to the therapy likely. So this is in all SCC before treatment, if you can able to do a immunophenotyping, we can get a good idea. And this is shows that this is also gender predisposed. This is what I have shown that male, female, they also show a little bit difference. Hence, for a NASH SCC, you find a gender, then find a hepatic immunological pattern, and by this you can helpful predict whether this person is going to SCC responsive or no. Because in SCC we find these two tumors, there is cold or the hot. Hot is the inflamed one, cold is that is either desert or exhausted. This one CD8. And this is also similarly, you can see for the PDL1 tumor infilled lymphocytes, this shows a diverse variation. So hot tumor is inflamed, which is likely to respond. Cold is which is slow, may not respond, and there is some other way you can think of making this cold tumor to a hot tumor. So you have to go multitude of actions targeting the T cell priming, trafficking T cells more into the tumor, increase the T cell infiltrations, to be T cell recognize the cancer cells, killing the cells by cytotoxic lymphocytes, tumor antigen elation, and this antigen getting again presented. So if you think that way, so NASH is a potential model where a cold tumor can be augmented to become a hot tumor or inflamed tumor to respond to the therapies. And we know the most important and most level 1 studies which have come up as RC to consider the first line drugs is the immunotherapy, particularly Sartali and Bevacizumab. But when they have considered these persons, it's a large trial, and here they shown that the NASH patients have a survival is with immunotherapy is relatively less, but they are better than lenvatinib group. Hence, this is a food for thought. However, after this paper, just 2-3 comments has come up that this study is only one study. This should not be considered as the full proof, and we need to more further. But this is where the NASH SCC, as far as immunotherapy is concerned, we have to think different way with a complete genomic, immunological and phenotyping mapping to be considered. This is a single study. I think that Pamicha is here can share. They showed that that if NASH SCC from Korea group showed that they have a more chance of developing recurrence because they are non-cirrhotic more, they have a large tumor, and after long time recurrence is little bit on the higher side. So we have discussed all the treatments predisposings. Now can we prevent? You can just see it is the only tumor where physical activity can decrease the chance, and diet, Mediterranean diet and Western diet, that modulate your inflammatory barrier, as we discussed gut yoga, which helps in prevention. And it is the only tumor where aspirin can use help for the long terms. And statins, there's a large number of studies, not prospectively, it is all the bystander analysis where they have shown that in NASH cirrhosis, if they are getting statins, the incidence of SCC is on the lower side. And coffee, there is a big meta-analysis where they are showing that 2 cup coffee. Previously, we know that for the NASH and fibrosis 3 to 5, here that in 2 cup coffee is significantly helpful in long term to prevent the SCC. So, all we know now about the SCC, from treatment to therapy to preventions, the most important is how to address them. So, are they different epidemiologically? Does see? Yes. Because here you have to see that they have a different genetic predisposition, they have a different carcinogenic process, they have a distinct genotype and phenotype. And at the same time, they are the only tumors where lifestyle interventions, modifiable risk factors, secondary level preventions we have discussed, they can helpful to make this approach. And most importantly, the NASH related SCC, if you think of, the genetic mutations varies across the geography. You can see India, it is ApoC, PPR gamma. So all country has a different genetic profile of the NASH patients, where we need to think that how we can provide a screening mechanism for them. Then most important is the NASH without cirrhosis is rising entity, and this is more common in SCC and HBV. Previously HBV is notorious, but NASH SCC is coming up, and how to identify them. And only few studies has come up with etiology specific model, but we are not aware that how to go for each etiology different way of screening and surveillance as far as SCC is concerned. So definitely we need a protocol which should consider genetic risk, phenotypic risk, non-cirrhotic to be addressed, and this ML screening is not standardized, hence we think of a separate surveillance protocols. So in that we have to think of what we already discussed. This is only a statement come from the AGA group that screening should be considered for all patients, even NFLD. The non-invasive biomarkers of advanced cirrhosis should be considered. NFLD, no advanced cirrhosis, should not be routinely considered. When quality ultrasound is suboptimal poor, you can think of doing a abbreviated CT or MRI. NASH cirrhosis should be counseled for the alcohol, and optimization of the lifestyle diabetes is concerned. So this is a guideline only existing, but which is also not clear, not patchy. And if you think of a protocol for surveillance, this is a big gray zone, how to go for mild fibrosis, advanced fibrosis and SCC. And here the few studies show that if you think of P4, NFS score, ELF and GALAD, so SCC risk you can get some with these cutoff values. So we need to address how we can go for, but this is obviously suggestions from this. Hence, this is I have taken a slide from here that if think of going for this surveillance, you also have to rope into the biomarkers. The biomarkers for the risk of SCC like the SNPs, biomarkers for the NFLD progressions like cell-free DNA, collagen biomarkers. You have to see for the imaging. These are multiple modalities needed to consider in addition to developing SCC markers. So just a suggestion and final concluding, if cirrhosis is there or no, we should be surveillance, should be considered, no doubt. If it is non-cirrhotic, consider the NIT as we have discussed. If these values are on the higher side as we have discussed here, P4, ELF or FibroScan 16 or MRE more than 5, we can think to be considered. And who are not having severe fibrosis, they may be excused. So this is how we can think of considering the NASH to go for. So at the end, surveillance screening needs a customized, not a default approach as far as SCC is concerned. We should address the geopolitical genetic aspect. We need an Indian registry because there is, I will come to the next slide, collaborative constitution biobank is needed. NASH SCC predictions should include from both bench and bedside, because what we have seen that India, the registry till now consider only the biopsy based diagnosis of SCC to be considered. That's why the incidence of India SCC is only 2% or less. And also this is not covered because SCC needs to be considered on this background. And this is the studies guidelines has been proposed, but is I think nothing foolproof how to address the SCCs. And here we need a collaboration. Thank you.